We will first hear from Dr. Evelyn Taiwo, an assistant professor of medicine at Weill Cornell Medicine and attending physician at New York Presbyterian Brooklyn Methodist Hospital. As a researcher, she has contributed to several studies on cancer presentation in urban and minority patient populations. For Dr. Taiwo's full bio, please go to lbbc.org. Dr. Taiwo is going to start off with a short presentation, and then we will be joined by our two panelists, Novella, who was diagnosed with early stage breast cancer in 2021, and Ativa, who was diagnosed with metastatic breast cancer in 2019. Welcome, Dr. Taiwo.
Hi, everyone. Thanks for having me. It's really an honor to be here with everyone who's on. I love doing this type of talks. Organizations like LBBC are so important. The work you do as it pertains to patient outreach, education, empowerment, and advocacy is so important. I'm going to share my screen and start my presentation. So I'm going to spend the next few minutes talking about just a general overview of breast cancer. I'm going to go over the epidemiology, staging, classification of breast cancer, and the treatment and supportive care that's necessary. I always start off with just talking about, the epidemiology of breast cancer. I think most people on here know that it's the second most common cause of cancer deaths in women after lung cancer. The good news is that the death rate has decreased by about 2.4% since the 1990s. This is for white women, and about 1% per year in Black women. So we do see that the risk of death has reduced for all women, but Black women still lag behind white women. We think the reason we're seeing improvement in survival really has to do with screening and early detection, as well as improvement in the treatment and the different options that we have. This slide here really just shows the incidence of breast cancer being higher in white women in the pink compared to Black women in the black. However, the mortality being higher in Black women. What's interesting, though, is we're starting to see the incidence in Black women starting to go up. And this may be due to increase in screening. So it may not be all bad, but there's still a whole lot of information that we need to get a sense of why we're seeing the incidence rising in Black women. This is just another slide showing that breast cancer it's the most common type of breast cancer. And I put the slide on there just so the women who are on here who have been diagnosed with breast cancer or living with breast cancer get a sense of how common this is and that you're not alone. There are many women and some men who are dealing with this disease. The next graph shows that the percentage of new cases of breast cancer by age group. This is still a disease that primarily affects women over the age of 55, from the age of 55 to about 74. But we do know that we see breast cancer present at a younger age, particularly in Black women. The median age of diagnosis is about age 62 in the general population, but we do see earlier age of diagnosis in the Black population. The reason is multifactorial, but we know this has to do with the higher incidence of triple negative breast cancer in Black women. So I think it's important to understand that breast cancer is not one disease. There are different subsets. When we look at all breast cancers, majority of breast cancer, up to 75%, will be hormone receptor positive. And you hear people talk about having estrogen receptor positive breast cancer. That's what that is. Another 15 to 20% are what we call HER2 positive. They have something called a HER2 receptor on their breast cancer. Then another 15% are the patients that have a triple negative breast cancer. So it's important to understand that not all breast cancer is the same. People and patients do wonder sometimes why their management is different from another person with the breast cancer. And a lot goes into how patients are managed, particularly the breast cancer subtype. This is a cartoon that shows the breast cancer classification that I talked about on the previous slide. When we look at breast cancer and we get a tissue from a tumor in a patient's breast, we're looking for three receptors. We're looking for the estrogen receptor, we're looking for the progesterone receptor, and we're looking for something called HER2. For patients who are considered hormone receptor positive, these are patients that have the estrogen receptor and the progesterone receptor on their breast, on the surface of the breast cancer cells. And for patients that are HER2 positive, they also have the receptor either on the outside of the cell or sometimes inside the cell. Patients who are triple negative are patients who do not have the estrogen, the progesterone, or the HER2 receptor on their breast cancer. And that's why it's called triple negative, because those three receptors are not present on the tumor. So moving on to breast cancer staging, we stage breast cancer from a stage 0 to a stage 4. A stage 0 breast cancer, those breast cancers that we call pre-invasive, those are the cancers that are DCIS or ductal carcinoma in situ. They're breast cancers that have not left the ducts, they're still within the duct, so that would be a stage 0. A stage 1 breast cancer is just a small tumor localized to the breast. A stage 2 tumor may be a slightly bigger breast cancer localized to the breast. Sometimes there are a small number of lymph nodes that are involved. A stage 3 breast cancer has a tumor in the breast as well as more lymph nodes when compared to a stage 2 breast cancer. And a stage 4 breast cancer is a breast cancer that is not only in the breast or lymph nodes, but has now left the regional area, and there may be tumors deposited in the lungs, the liver, the bones, and some other areas that breast cancer breast cancer cells like to settle in. Now, moving on to genetic testing and the importance of genetic testing. There are times where patients wonder and question why they've gotten a breast cancer when there is no genetic abnormality. I think it's important to understand that most breast cancers are not associated with an abnormal breast cancer causing gene. When you look at this pie chart, you can see that the no breast cancer gene mutation is the majority of patients. Then we have breast cancer associated genes in another 5 to 10% of patients. And even within the patients who have a breast cancer causing gene, I think BRCA1, BRCA2 are the genes that are the most that people are the most aware of, but there are other types of breast cancer associated genes. So I think it's important to know that besides BRCA1 and 2, there are other genes that also do exist. But for a patient who's got a BRCA mutation, there's an up to 50% chance of breast cancer by the age of 50. And up to 87% of breast cancer diagnosis by the age of 70, and another risk of second breast cancer in someone who's already been diagnosed of an additional breast cancer by the age of 70. So the BRCA mutation really does confer an increased risk of breast cancer. The BRCA mutation is often found in patients with triple negative breast cancer, which I mentioned earlier. We see a higher incidence in Black women. That being said, most triple negative breast cancers do not have a mutation in the BRCA1 gene, and most are sporadic. However, 10 to 15% and up to 30% of African-American women or with triple negative breast cancer harbor a breast cancer causing gene, particularly BRCA1. So 30% of African-American women compared to 10 to 15% of white women have this gene. So it's important to get genetically tested to get a sense of the risk of a secondary breast cancer, as well as other cancers that are associated with BRCA1. This slide just shows the extensive number of genes that are also associated with breast cancer. You see that the BRCA1 is about 28% of the breast cancer causing gene, BRCA2 another 12%. There's a gene called PALB2 in 19% of patients. There's ATM, there's CHEK2. I'm not going to go through all of them, but I think it's important because having Knowing that there's a BRCA1 or 2 is important, but also knowing if there's the presence of other types of genes is also important. So BRCA1 and 2 are not the only genes that can increase the risk of breast cancer. We do know that the rates of genetic testing in African American women is less than their counterparts. Part of the reason is lower patient awareness, also lower provider referrals, and lower access to genetic testing services. And the lower rates of genetic testing are leading to just lower probability of early detection for patients who have a breast cancer causing gene. The screening recommendations and the screening guidelines are different. So knowing if one has that gene could help start screening earlier. The inability to know what a patient's status is may also lower their clinical trial eligibility. Sometimes these trials require knowing a patient's BRCA status. And we now have treatment modalities that are available, particularly with drugs called PARP inhibitors that we use in patients that are BRCA positive. The inability to know what a patient's status is makes it difficult to offer these treatments that are available. So I say all of this to encourage patients to get genetic testing. Obviously, there are guidelines as to who should get tested, but the conversation with an oncologist, a medical provider is important, particularly in African American women, where there's still a lot unknown about the disease and what contributes to the higher risk of more aggressive tumor biology and lower survival rates. So moving on to the important part of this talk for patients who've been diagnosed or living with breast cancer. Throughout this breast cancer journey, a lot of it starts off with a patient either presenting with the tumor in their breast or an abnormality detected on screening mammogram. It starts off with the biopsy with the radiology department and pathology. And then once a diagnosis has been made, generally a patient is referred to a breast surgeon in combination with the plastic surgeon if that's necessary for that patient. And then the other services, the medical oncologists, the radiation doctors, pharmacists, nurses, dietitians, these are all the different treatment modalities and different services that are involved in the management of a breast cancer, a new breast cancer diagnosis. I know this slide shows, 1, 2, 3, 4. Oftentimes the 4 the 3 and the 4 don't necessarily go in that order. Sometimes a medical oncologist would be the first person a patient sees, but this is just a nice slide showing all the important groups that are necessary to treatment and management of a patient with breast cancer. In terms of breast cancer treatments, there's the surgical aspect. There is the chemotherapy, which I think most people are aware of. Not everyone requires chemotherapy. We do have hormonal therapy for appropriate patients. We have targeted therapies, which are the monoclonal antibodies, and we have immunotherapy for appropriate patients, and then radiation. But treatment really varies widely depending on the characteristic of the cancer, the patient's preferences, and the patient's comorbidities. So not all cancer treatment is the same. In terms of treatment, it really depends on the type, like I mentioned, but also the stage of breast cancer. For patients who have stages 1 to 3 breast cancer, the treatment is usually a combination of surgery and chemotherapy, and oftentimes radiation will be part of the treatment. For patients who have small sized tumors, less than 2 centimeters, surgery is often the first treatment modality. For patients who have greater than 2 centimeter tumors or positive lymph nodes, there's often a discussion with the surgical and medical oncology team as to, whether some sort of medication or chemotherapy or immunotherapy is required before surgery. So there's often a conversation with those two teams to determine the order of the treatment plan. For patients who have stage 4 breast cancer, the treatment is primarily with medications. Sometimes that's anti-hormone treatment, sometimes that's chemotherapy, immunotherapy, antibodies. For patients who have painful lesions, radiation may be offered. For patients who are coming in with brain lesions, radiation may be part of their treatment. but really the treatment is palliative, which means it's to control disease, to manage symptoms. Rarely is surgery considered, except if there's a brain lesion. And the reason why is in a patient who's metastatic, where disease is outside of the breast, the surgery is not contributing to improved survival since the tumor is now out of the area that it started. So usually radiation is suggested if someone's coming in with, say, a breast lesion that's very painful, that's bleeding, that's getting infected on a regular basis, but rarely is that offered. So it's really some sort of treatment that's offered to stage 4 breast cancer patients. And many of these patients can live for a very long time too. And so in terms of when to give chemotherapy before surgery, this is called neoadjuvant chemotherapy or pre-surgical chemotherapy. We're doing this more and more because we're getting a lot of information from patients getting some form of treatment before surgery. Traditionally, we were giving chemotherapy to patients with breast cancer to improve cosmetic outcomes following surgery. We would also give it to patients who we were pretty confident would get a good response to the treatment, and it allowed us to assess the tumor response. And then giving chemotherapy before surgery was also, offered for patients who had contraindications to undergoing surgery at the time of diagnosis. So patients who were pregnant. But now we're using chemotherapy as a way to de-escalate or sometimes to escalate further treatment. If we're able to assess a tumor's response to chemotherapy, then it allows us to assess whether additional treatment is necessary or we can actually reduce the treatment we're giving to these patients. So it's really helpful in getting additional information. And we're moving more and more towards giving chemotherapy first. And this is for patients where it's been determined that chemotherapy is likely going to be beneficial. This is not for all patients. That is sometimes a cause of anxiety for patients who wonder why surgery is not being done right away at the time of diagnosis. We have studies showing that whether chemotherapy is given before or after surgery, their survival is essentially the same. And that's what this graph shows. Moving on to the surgery and the type of surgeries that are done, we don't do radical mastectomies anymore. Those were pretty invasive, very disfiguring surgeries that were done up to the 1980s. For patients who require a mastectomy, a modified radical mastectomy is done, which is not as disfiguring as a radical mastectomy. The goal is generally to conserve the breast, where we do lumpectomy with radiation. And that's always the goal, but there are times where that is not possible, whether it's due to the tumor, the patient's breast size, the multifocality of the disease, or patient preference. And then we also do consider genomic testing when we're trying to determine whether chemotherapy is going to be beneficial or not. Like I mentioned earlier, not every patient requires chemotherapy. We now have additional testing in certain tumor types, particularly in the hormone receptor positive breast cancers. We do tests such as Oncotype or Mammoprint to help us determine whether chemotherapy is beneficial in this patient, or if we can get away with just endocrine therapy only, which is the anti-hormone treatment. Moving on to what chemotherapy is. Chemotherapy is really systemic treatment. It's therapy that travels in the bloodstream throughout the entire body. So I think when we talk about chemotherapy, there's this narrative that it's going to be treatment that causes significant toxicity. That does exist, but the chemotherapy is really just any treatment that you're getting through the bloodstream. And so the monoclonal antibodies, the immunotherapy drugs that are not really chemotherapy, have all been put under that same umbrella. So it's just important to understand the nuances of what it means when someone says they're getting chemotherapy. Usually for a patient who's going to get chemotherapy for their breast cancer, it's given intravenously, sometimes through a regular IV, like the picture on the right. Sometimes we require something called a Metaport, which is just a venous catheter that's put in the chest wall. And it's a way to get easy access to the vein. The chemotherapy would be given through that port, and that gets the medication through the system. There's certain chemotherapy regimens that we prefer to do a Metaport. And for patients who are going to be on a prolonged treatment course, a Metaport is also useful just so we're not sticking the patients oftentimes for blood draws or even for chemotherapy. And there are treatment side effects associated with chemotherapy. Hair loss is common, sometimes nausea, sometimes diarrhea, other times it's constipation, sometimes it's neuropathy, which is just irritation of the nerves that certain chemotherapy drugs cause. But many of these treatment side effects are manageable, whether it's the anti-nausea medicine, anti-diarrhea medicine. These are all available and should be given to patients prior to starting treatment. So it's all available at home, and you can use that if you do experience side effects. We're doing a lot better job than decades prior in some of the supportive treatment for patients who are on chemotherapy. And then as it pertains to patients who are getting hormone therapy, even though it's not chemotherapy, they do have their own side effects too. Sometimes hormone therapy, traditionally and typically it's used post-surgery, but we're sometimes using it pre-surgery, the same way we give chemotherapy to certain patients pre-surgery. We're also using hormone therapy in certain patients pre-surgery as well to shrink the tumor. But they do have their own side effects, such as hot flashes, night sweats, the vaginal dryness, some variation in periods. And all of these are side effects that are also manageable. For hot flashes that are terrible, sometimes low-dose antidepressants are used to help patients with the side effects. So I mentioned the anti-nausea medicine, anti-diarrhea, anti-constipation medicine. There's something called a magic mouthwash we use for our patients who develop sores in their mouth. Just this mouthwash and rinses are very helpful when there's mouth sores and just tenderness in the mouth from the chemotherapy. For patients who struggle with blood counts dropping and becoming very low white blood cells, we give injections like Neulasta, Neupogen, or Onpro. Sometimes we give it as prevention, because there's certain treatments that we know will definitely cause a patient's blood count to drop. We don't want it to drop too long. When I say blood count, I'm talking about the white blood cells that fight infection. If they're low for too long, there's an increased risk of infection. So as a way to prevent that and speed up the recovery of the white blood cells, we give this medications or injections like Neulasta. I mentioned the low-dose antidepressants that are used for hot flashes, and then for bone health, we recommend calcium, vitamin D, because this anti-estrogen medicines can speed up the rate of bone loss, because estrogen generally is good for the bones. And moving on to radiation, many patients who are getting lumpectomies will also require radiation. There's very good data that shows that lumpectomy with radiation is just as good as getting a mastectomy, and says it's not necessary for women to lose their whole breast. If they don't need to, then for patients getting lumpectomy, radiation is generally offered. It's targeted treatment to the breast and the regional lymph nodes. There are different types of radiation. There's the external beam, which is the most common and traditional form of radiation in breast cancer, but sometimes brachytherapy is offered. It's where they put in radiation, they put in catheters, and radiation is delivered through those catheters. And then talking a little bit about clinical trials, I think this is important when it pertains to Black women. We know that there is a lot of distrust for very good reason. They've been unethical practices for decades, which have made people in the African-American community somewhat cautious about being on clinical trials. When it comes to cancer care, clinical trials really are the mainstay in development and validation of new cancer therapies. It's hard to assume that a medication that works in one particular group will work in the other, but without having patients from these underrepresented groups, it's hard to know whether our treatment modalities are actually beneficial. So we do know that the disparities in clinical trials is really stark for racial and ethnic minorities. We actually show data showing that the enrollment in clinical trials has decreased over the past 14 years. While we see that in cancer care in general, clinical trial participants are disproportionately non-Hispanic men who tend to be more educated and have higher incomes, so underrepresented minorities, and also patients who have lower incomes are not being represented in many of the trials that are being done. So clinical trials are important because they are representative and provide more accurate information on effective treatments, which should then lead to improved survival for all patients. This graph, once again, just shows, this slide, shows what I just said. When you look at the United States population, Caucasians is 72% of our population, Hispanic 16%, African Americans 12%. But when you look look at clinical trial participants, it's 94% Caucasians, African American about 5%, and it's even lower for Hispanic patients. So it's important to understand the why being in clinical trials, if there is one that's available. Not everyone needs to be on a clinical trial. Most patients who've been diagnosed with breast cancer are not going to be on a clinical trial, but it's important to ask if those clinical trials are available, or if there's one that you or your loved one may benefit from. And then moving on to the survivorship phase, which is the phase post-treatment. There is life after a breast cancer diagnosis for patients who have early stage breast cancer, and even patients who are metastatic. But when we talk about survivorship, it's primarily in patients who have early stage and they're done with their treatment. There is ongoing screening with mammograms, but then we start focusing on other medical issues, other comorbidities for patients who have hypertension, diabetes, obesity. That is something that we know increases the risk of breast cancer recurrence and breast cancer in general. So modifiable risk factors are things we start focusing on in the survivorship phase. Counseling, lifestyle changes, bone health is an important one for patients, particularly on an anti-hormone treatment. There are patients who have cognitive impairment. People call it chemo brain, emotional and mental unwellness after a diagnosis. A diagnosis of breast cancer is very traumatic for many patients. And at the end of the treatment is when a lot of people start processing what's happened. So really focusing on mental health and in the survivorship phase is important, as well as second cancer screening, the colon cancer, cervical cancer, all of that. And then for patients who are metastatic, the treatment goal is really to improve survival, minimize tumor burden and symptoms related to the disease, and prevent complications related to the disease, just to help patients live longer. And of course, to improve the overall quality of life. So there are tons of treatments that are available for metastatic breast cancer patients. I often think we don't talk about it enough. A stage 4 diagnosis definitely doesn't mean life ends. It means life just changes. And so it's important to know that. It's important to advocate for yourself. It's important to ask questions. And it's important to find providers who understand and also believe that too. So this is my final slide. And my take home is that there's treatment for all breast cancer stages. One size does not fit all. The treatment side effects are manageable and very treatable. Important to discuss genetic testing and enrollment in clinical trial with providers. And please advocate for yourself and do not be afraid to ask questions. I tell patients, if there is a medical doctor, a provider who is frustrated by you asking questions, it may be time to find a new doctor. Patients who ask questions are advocating for themselves. And by doing that, it allows us as providers to do a better job. So I'm a big supporter of advocating and asking questions. And that is the end of my talk. Thank you.
Awesome. Thank you so much, Dr. Taiwo. This was an awesome presentation, a lot of great nuggets that you shared today. And for those who are tuned in with us and on the chat, be sure to put your questions in the Q&A section featured at the bottom of your screen, and we'll get to as many questions as we can throughout the program. Now, I would like to welcome our panelists to the screen, Atiba and Novella.
Hey, here we go.
Welcome, Novella. Welcome, Atiba.
Thank you.
Thank you so much for joining us. And Dr. Taiwo presented a lot of great information for us and gave us a good overview of what's important for us to really understand about our diagnosis and treatment. And Atiba, Novella, I want to ask you a few questions. Did your providers discuss your diagnosis and treatment options? And Atiba, really understanding that you were diagnosed with metastatic breast cancer de novo, meaning right from the beginning, you were stage 4. So I want to start with you in answering that question. Again, did your providers discuss your diagnosis and treatment options with you?
So the short answer is yes. However, the realistic answer is, even though they discussed it, I wasn't in the right mindset to really understand it. So for me, I didn't know anyone that was ever affected with breast cancer. So I wasn't aware that there would be a treatment plan, that the doctors would need time to have a treatment plan. So for 10 days, I laid in bed and cried because it was just silent. I didn't understand at the time the silence was because they were gathering to work on my behalf to create a treatment plan for me since I was de novo.
And Novella, what about you?
Well, when I went in and received my diagnosis, I was told, you have breast cancer, and this is the type of breast cancer that you have in your right breast. After that, I pretty much was like, okay, so what do I do now? I've never had breast cancer, and no one in my family has ever had breast cancer. So she told me also, well, we'll just have to wait and figure out what the treatment plan is. It could be chemo, or it could be radiation, or it could be both. We are just not sure yet. And I was given a handful of paperwork that had, a lot of different medical terms and terminology in it. And they were like, okay, here, go read this paperwork and let us know if you have any more questions. And I was completely confused. I was horrified, of course, because that is not what you want to hear, is I've been diagnosed with breast cancer. So I walked away confused, just like Atiba, boo-hoo crying, because I'm thinking I'm about to die because no one has explained to me what's going to happen next. What is my chances of survival? So I was kind of in that same state.
Yeah. And, when we go through these things, we have so many questions, but right, like Atiba said, when you hear it's cancer, you just go blank. But we want to bring Dr. Taiwo back on with us because we're probably going to have some questions for her. So Dr. Taiwo, if you can actually join us again, that would be great. So Novella, I want to ask you this. We're talking about, clinical trials. This is one of the things that we're really having a lot of conversation about. So did your doctors talk to you about clinical trials, or even did they talk about genetic testing with you?
Clinical trials, not at all. That was never brought up in our conversation. They never really talked to me about genetic testing. Also, I happened to get an email from the hospital saying, hey, we want to set you up with some, this particular person to do genetic testing. But no one had told me about it. But I went anyways, and I listened to everything that, he had to say. And I said, yes, sign me up for genetic testing. I want to know if I have the marker. And then I want to know if I have any other markers besides breast cancer. So I definitely signed up for it and found that I had no genetic markers, no testing for breast cancer or any other cancers.
Yeah. So Atiba, what about you? What was your experience with genetic testing, and as well as having conversations around clinical trials?
So until I was diagnosed with breast cancer, I didn't even know genetic testing existed. So it was extremely important for me to go through with it, being diagnosed with de novo. I wanted to give anyone coming behind me the opportunity to learn and be educated sooner than later. When it came to clinical trials, they did talk to me about it, but it wasn't with hope. Because the reason is, what a lot of people don't realize is, even though we do raise our hand for clinical trials, pre-existing health conditions often keep us from becoming part of the trial. So being someone that is obese, and there's things that come with that, it's often that I may not have been selected. So they did talk about it, but it wasn't as positive as it could have been for someone who's either early stage or even that of a normal weight.
Yeah, I remember when I was actually diagnosed with breast cancer, and I had genetic testing, and when the results came back and said, I didn't have any kind of genetic mutation, and they asked me if I wanted genetic counseling, and I really didn't understand it. It was like, well, I'm negative, so what does that mean, and why do I need counseling? And no one really explained that to me. And so, Dr. Taiwo, I would like to ask you about that. When we get these phone calls, whether we do have a genetic mutation or not, should we actually undergo the counseling that is offered?
Yes, absolutely. I think genetic testing without counseling could be a cause of distress in patients who have a gene. I think it's important to know what it means to get a positive test or even a negative test. And now, because we're testing more patients, we're also finding things called variants of unknown significance, which are the VUSs. It's also important for patients to know what that means. What a genetic counselor does is they are a bit more intense in getting a family history. They basically create a family tree. And then if a patient has a genetic abnormality that increases the risk of breast cancer or other cancers, they're able to figure out who else may benefit from genetic testing in your family. The whole point of testing starts off with testing a patient who's been diagnosed with a cancer, and then who else may have inherited that gene, so that person can get tested, whether it's your sibling, whether it's your offspring. They can get tested, and then they can start getting screened earlier. For patients who have a BRCA mutation, who are young, we screen them starting at the age of 25, not age 40 in terms of mammograms. We do not just mammogram ultrasounds. We also will consider MRIs in these young women. So that's why the counseling part is important, to get that whole family history and who else may benefit from testing and not have to pay out of pocket for it, right? If you're positive and your child who's 22, because we don't test in our minors, and your child who's 22 wants to get tested, insurance is required to cover it because there's a parent who is positive.
Yeah. And since we're on the subject of, talking about clinical trials, I know we talked about genetic testing, but I want to jump back to clinical trials. How do we find out about clinical trials? If our doctors aren't having these conversations with us, what do we do and where do we go? And Dr. Taiwo, I'll pitch that question over to you.
Right. So there's a website called clinicaltrials.org where patients can go, although it can be a bit overwhelming for a lay person to understand what's on that website. I think the most important thing is, talking to a provider. So what we're also trying to do, besides just talking about the importance of clinical trial, talking to providers to understand what that actually means, and then finding institutions that have those available, right? That may be patients who live in more rural and more secluded parts of the country where getting to a tertiary center is difficult. But having that conversation with your doctor and then asking, is there a place where I could inquire about a clinical trial? Sometimes just a televisit to ask about it is all that's needed. Sometimes it's a run-of-the-mill breast cancer where a clinical trial is not essential. We know how to manage, we know how to deal with it. There's a pretty well-established standard of care, but just even asking, I think, is important to normalize and demystify what it means to be on a clinical trial.
Thank you. So I just want to switch gears for a minute. We've talked about clinical trials. We've talked about genetic testing. We've talked about just even having a discussion around our treatment options. Let's talk about being a Black woman with a lived experience of breast cancer. When it comes to being Black, have you ever, and this is Atiba and Novella, was there ever a time during your treatment when you realized that your diagnosis was actually different because you were Black? And Atiba, I'll start with you.
So that's a great question. Being that I didn't know anyone who ever had breast cancer, it wasn't an area that I studied. Like we're all taught, check yourself and all of that jazz, but no one really gets down, hey, did you know there are different types of breast cancer? So being someone that was diagnosed with inflammatory breast cancer, it was pretty scary. And I say that to say because it's even a smaller group of women that are diagnosed with the type of cancer that I was diagnosed with. So it was tough to really look. I had to talk to my social worker to try to find a Black women's group, and I couldn't find one in New Jersey. And thankfully, I met Tia in Atlanta. So it just shows you sometimes even with the different types, it's also limited resources for us too, just to be able to say, hey, sis, is there anything that you can tell me? Or this is what I'm being heard. Is that right? Like, it's just a lot sometimes.
Yeah, and to hear you say that, when I was going through back in 2015, I was looking for those supportive services. And I didn't see anyone that looked like me, both being young and being a Black woman. And, I started the sisterhood that you became a part of, but also with that, you're starting to see more and more Black women start their own nonprofit organizations, starting their own support groups, like a lot of the anchor partners that we have here today. And it's because this was a gap. It's missing. And I'm so thankful that we have anchor partners like Touch and Tiger Lily and For the Breast of Us, and of course, My Style Matters, as well as the Chrysalis Initiative that's helping to address these issues and bringing us together. And we thank LBBC for helping us to even, further our voice like we're doing tonight. So I want to ask you, Novella, we asked Atiba about, did she ever think about her diagnosis and being different, being Black? But did you ever have a conversation with your doctor about being a Black woman and having breast cancer, having been diagnosed with breast cancer?
I didn't know to ask. I had no idea what I was supposed to ask my doctor. I was in a state of shock that I even got breast cancer. So my breast surgeon is Caucasian. So I felt as if she was probably just treating me the same way as any other woman that would come in there that was diagnosed with breast cancer. I later found out as a Black woman that most Black women have dense breasts, and they were saying, oh, you have dense breasts. You should have your mammograms, you should have your ultrasounds, so that we can see additional, tumors if they're there. I learned so much after having breast cancer and having connected to other women, Black women who had breast cancer, of things that I needed to look out for, how different side effects may impact me because I was a Black woman. I didn't find out any of this information until after the fact. And I wish I knew ahead of time so that I could have been better prepared.
Absolutely. And Dr. Taiwo, you've participated in studies on cancer presentation in minority populations, but can you tell us, what have you learned when it comes to Black women and breast cancer? I know you've talked about some of those things in the presentation, but I want to hone in on it just a little bit more. What are some of the things that you're finding that we really need to have more conversation about and be able to address like we're doing tonight?
Yeah, I think a lot of what we see is that women do present at a later stage. We've talked about the fact that triple negative is more, has a higher incidence in Black women. My hope and goal for a lot of what I do and what you do is really to encourage screening. What we found, there was a study that was published last year or 2 years prior, where they actually showed Black women who are diagnosed with triple negative breast cancer from a screening mammogram actually appear to do better than white women, right? Compared to women who are diagnosed by a mass that they palpated and presented with. So I think just presenting early is important, which means screening is important. Yes, dense breast could increase the risk of breast cancer. We're not sure if it's that the breast density increases the risk or the breast density makes it difficult for a radiologist to actually see the breast on a mammogram. In New York State, I'm not sure about other states, when a patient has dense breast, it's actually required by law to state that in the mammogram report. So then that forces the person who ordered that mammogram to decide if they want to do ultrasound in addition to the mammogram. So those are the things that we're seeing that we're presenting later. And so screening is important. We have more dense breasts, so ultrasound with the mammogram may be part of what is required. And then, we have more sophisticated mammograms now. Everyone really should be getting the 3D mammograms. Those are the mammograms with the tomo. So if you're going to a facility that still has the old school mammogram, that's not going to cut it.
So I'm going to pivot because we have a lot of questions that's coming through in the chat. So I want to ask you this question. When we think about Black women, since we're having this conversation about Black women and breast cancer, when it comes to our treatment options, depending on the insurance that we have, does that really impact the type of treatment that we're going to get? And Dr. Taiwo, I think you're a very great expert to really answer this question. How does your insurance impact your care?
It shouldn't, and it doesn't. Prior to being at Cornell and NYP, I worked in a city hospital, and those patients who came through our breast center got the standard of care. So it's just getting the chemotherapy approved, which as long as the provider is giving the treatment for justifiable reasons based on evidence, then your insurance should not prevent you. Even with the newer, more expensive drugs, the monoclonal antibodies and the immunotherapy, that should not prevent a patient from getting standard of care. I think what's important is really having a physician who understands what standard of care is, who's up to date with, oncology and particularly breast care could be very overwhelming. I mean, it's a good problem that we're now having where there's a lot of information that's coming out. There's a lot of research that's really causing us to pivot and make changes in how we manage patients. So finding a provider who's up to date really is what's the most important. Your insurance type should not prevent you from getting the care you need. Sometimes we as doctors have to do what we call peer-to-peer, because then you have to fight with insurance companies to cover what you know is needed. And usually they will approve it. Rarely. You may get a denial for certain imaging modalities, whether it's a PET CT scan versus a CT scan, which that's not going to change, management and when you look at the big picture. But as it pertains to the drug, we rarely get denials. You just have to show why it's necessary.
Yeah. And I know, there's a study that came out that said that, Black women, African-American women, and Latino women are 30 to 40% more likely not to get standard of care. So, we ask these questions of what do we do when we're in those situations and we're not too certain if we're really getting standard of care. And some of us don't even know what standard of care is, which is why we're having this conversation tonight. So knowing this statistic that Black women, at an alarming rate are not getting standard of care, what can we do? What do we do about that? And how do we address that?
No, that's a great question. And it's not a patient's responsibility to know what standard of care is. They are the patients, not the physician. What I start telling family members and friends to do when you see a new doctor, and this is, just for all medical issues, I think acknowledging and telling your doctor, I'm here, I'm scared, I have a breast cancer diagnosis, I'm a Black woman, and I know what the statistics are. I need you to tell me and reassure me that I'm going to get the best possible care, that I'm going to get the care you would give to everyone. I think you say that to a doctor, it allows, they calm down and it's like, okay, this is a patient who's coming in to advocate for themselves. Any patient who comes in advocating, asking questions, keeps me on my toes in a very good way. I can't miss things. I need to be on it. So I really do recommend that to everyone. Just tell your doctor, I know what the statistics are. I do not want to be a statistic, and I need you to help me make sure I'm not a statistic.
Yeah. And oftentimes we do ask those questions, and sometimes we ask a lot of questions. And so I want to ask Atiba Novella, sometimes Black women get labeled. We get labeled as an angry Black woman. So how do you advocate for yourself without being labeled as an angry Black woman? And so I want to ask that question. Atiba, I want to start with you.
So it's exactly what Dr. Taiwo said. When I meet anyone, especially, that's one of the tools that I put in my toolkit. When I meet anyone, I start the conversation. Look, I know our communities have had some differences. There's history of that. However, in this moment, when we interact, I need you to treat me like you would treat your mother. And that really just level sets the conversation. And I did that with my brain surgeon. And the next thing he said is, you know what? Thank you. And can I have a hug? And that calmed us both down to really, it allowed me to let go of because my wall was up, it allowed me to let my wall down so I can sit in front of him and really hear what we're going to do together.
Yeah. And that's really good that you had that experience, but we know that 3% of oncologists are Black. And sometimes we go out and, Dr. Taiwo, she kind of listed all of the different people that we need on our team. And sometimes we want to find someone that looked like us, but unfortunately, like I said, there's only 3% of oncologists are actually Black. So Novella, how did you navigate that process? Were you looking for Black doctors to be on your care team?
I was still in that state of shock. I just wanted some people to take care of me and heal me. for lack of better words, of the breast cancer that I had. So how I approached it is I just pretty much told them, I'm going to ask a lot of questions. Please forgive me up front, but this is new to me. And in order for me to relax, I have to ask questions in order to get like a better understanding of what's happening to me. But also with the medications, if I'm being given any type of medication, I feel more comfortable if I know what the medication is and what the side effects are, so that I can be aware if anything does happen. And I just approach every communication with every medical provider that way. I apologize up front, but I'm going to ask you a lot of questions. So please be patient with me. This is my first time having breast cancer. So that tended to kind of calm the area or the room down a little bit. And they were very patient with me from that regards. I was very blessed that I did have a African-American female radiation oncologist. And I was like shocked to see her. So I'm going to be, all of the people that was on my care team were Caucasian. So when I walked in, and this is the crazy part, her last name was Brown, just like mine. So I went in and I saw her and I felt at ease because I felt that she's going to understand what's going to happen to my body. And she'll be able to tell me what's going to happen to my body. And she was. And the same thing with my occupational therapist. She was an African-American female, but she was also a breast cancer survivor herself. And that just put me at ease from the get-go.
Yeah. And Novella, before we had a conversation about just your experience and your journey, and what you shared with me is that, you were very directive with your breast surgeon, and you really wanted your breast tissue, when you had your surgery, you wanted your breast tissue removed during your mastectomy. And you said that your surgeon tried to convince you to retain some of that tissue, but you were very, very clear that you wanted it all removed.
Yes.
And your surgeon actually left some tissue in your body. And then you also shared a very difficult experience with me where you repeatedly was trying to communicate to your nurses while they were administering medication to you that something just wasn't right. But they didn't listen to you. So can you tell us, how did you actually get them to listen to you?
Yes, so the breast surgeon, I got a bilateral mastectomy, and I did not want reconstruction. I was very clear with her from day one, take both of the breasts. I do not want reconstruction, remove all breast tissue. So I thought we were clear. We had surgery. I woke up. She came to my bedside and she said, I know you told me you didn't want reconstruction, but I left breast tissue there for you and skin so that you can get reconstruction in a year or 2 or 5 years down the road, because I know you're going to change your mind. And I was devastated. I was already devastated just by having the surgery, knowing that I was going to have chemo and radiation therapy. But because she left breast tissue and skin, is devastating by itself, because I have to look at that every day, knowing that she overstepped my boundaries and my will while I was unconscious. So that was another one. It's kind of like hindsight. There was nothing I can do while I was sedated. So I have, this breast tissue and skin left over. Now, during my chemotherapy sessions, when I knew the drug that they had given me was giving me some sort of reaction that was not good, I screamed out in the chair, connected through my port, I'm sick, something is wrong, I feel sick. And they heard me, but they did nothing. And I did that for 30 minutes and they still did nothing. But I heard everything. So I wrote everything down. I talked to my oncologist and they listened to me. He removed the medication off of my chart and rearranged my medications for chemotherapy. And I never had that issue again. So at that point, write everything down, talk to your provider, share it with them. They will listen, but you have to keep speaking to them for them to understand I'm serious.
And Dr. Taiwo, just listen to Novella's story. I want to ask you this question. Novella spoke out. But sometimes we find ourselves in situations where we're too afraid to speak out. We may live in communities where we don't have access to other providers, or we may have, an insurance carrier or health insurance that may not allow us to go what we call fire our doctors. So in those instances, what do we do? What do we do when we feel as though our hands are tied and we feel hopeless? What can we do to make sure that we're getting the care that we need and we deserve?
Like I said on my previous slide, you have not only the surgeon, you have the medical oncologist, you have the radiation doctors, you've got your dietitians, you've got your nurse navigators, the access nurses. There are a whole group of, teams that are dedicated to taking care of patients. So within that group, and I've actually had patients who I found out they had some concern, maybe not necessarily related to their treatment, but they wanted to ask a question that they thought was inappropriate. Then they would ask my nurse practitioner, or they would talk to the patient navigator about it. And then that's how he got back to me. And then we're able to have a conversation about it. So I think within that group, you find people that you trust, because there will be people with with that group that's taking care of you as a patient. There'll be a nurse, there'll be a physical therapist, there will be someone that you should feel like, or that's present to listen to you, and then can get that back to, your provider. So that's what I generally recommend. Find someone who gets you. It could be the front desk person, right? We're all part of the team and we're all constantly communicating. And sometimes just take someone with you. Sometimes when a patient shows up with their child or their mother or their partner, it's different. It's like, oh, game on. I got to talk to two people now. So the pressure is on in a good way,
Yeah. So Novella talked about she was having a reaction, and we're getting a lot of questions in the chat about side effects. So what are some of the things that we can do when it comes to side effects like neuropathy or hair loss? And, is that hair loss a permanent situation? And then what do we do? How do we manage and navigate those side effects?
Right. So hair loss is not permanent. Most patients will recover hair after they're done with chemotherapy. For certain patients who are really determined to not have a lot of hair loss during their treatment, there is the scalp pulling device that's available. We don't have a whole lot of data in Black women. I've used it in a few Black women and have had success with some and not so much with others. It's also not covered by insurance right now. It's out of pocket, $275 a pop each time, each cycle. So that's not always the easy route for most patients. But most people will have recovery, after chemotherapy associated alopecia. You may have some people who don't fully recover on their hair. Maybe they had some alopecia issues even prior to starting chemotherapy that was being masked. And then the chemotherapy just sort of brings that all to light. But most patients will recover. As it pertains to neuropathy, the key to neuropathy is actually trying to stop the chemotherapy before it develops to a degree that's significant. We rate neuropathy from a grade 1 to 4. So for patients that are on a drug called paclitaxel or Taxol or Taxotere, those are the drugs that really can cause the neuropathy. So I'm very aggressive, and many doctors are very aggressive about asking, do you have any numbness and tingling? If it's a grade 1 or grade 2, we don't do too much about it because it's tolerable. Anything higher than that may warrant dose reduction. Anything higher than that may warrant stopping the treatment altogether and switching to an alternative therapy. There is some data that patients who wear the frozen gloves, kind of like the same thing happening in the scalp, that may also reduce neuropathy. I don't generally recommend that a lot because a lot of my patients are also diabetics. So if you're diabetic, you already don't get good flow to your digits, to your fingers. The frozen gloves may actually make that worse. But in patients who don't have diabetes, don't have any nerve problems, that's also another way to prevent neuropathy.
So we talk about these side effects. What about some of the uncommon side effects that we may not hear about or people talk about, like nasal sores or things like an allergic reaction to the chemo? And we know that Black women, we don't have a large participation of Black women in clinical trials. And so sometimes when we have these experiences, kind of similar to Novella, where her, the nurse said, no one really has a reaction. This is uncommon. We haven't seen it. And so they chalk it up to being something else. So what do we do about that? And are we starting to see more Black women have these types of experiences, and are we coming forward to talk more about it? What are you seeing in your practice?
I think at the end of the day, it really has to do with being in a facility where it's not even necessarily about having a doctor of color. We talk about the importance of workplace diversity, having nurses of color, having social workers of color. All those things are important. What you realize is that, when you have different groups of people working together, then it's very easy to see another person's humanity and not just chuck it up to being overly histrionic or overreacted. There are very clear documented cases of allergic reactions to certain types of chemotherapy, paclitaxel, Taxotere. Those are very, very common. And I think the important thing is always to just err on the side of caution. A patient has a reaction. If I'm not clear that it's an allergic reaction, we stop until proven otherwise. So I think once again is finding, and when you feel like your safety is being compromised, make a scene. We don't want that, but if you have to save your life, make a scene.
Yeah, absolutely. So let's talk a little bit about, the health administrations. How do healthcare administrations view their role in addressing inequities in breast cancer access and outcomes?
Oh, that's definitely something that's become more prominent. I think when you think about 2020 and the social justice issues that were happening in the country, I think it was a wake-up call for the whole country and for healthcare institutions as well. So I know where I work, which is the New York Presbyterian, there is an endowment, there is an institute that's dedicated to healthcare, cancer, sickle cell, all those things that pertain to diseases affecting people that are underrepresented, with the goal of really narrowing disparities. And we're talking more about health equity. So I think many institutions are aware of this and they're putting things in place, whether it's hiring doctors of color, having a more diverse workplace, and then being open to doing research that has not been traditionally the most important. I think everyone's realizing if marginalized communities in the country are healthy, then everyone is healthy, right? So I think even how this benefits the whole society at large is becoming more and more obvious to the higher ups, and they are instituting policies and restructuring to make sure these things are part of the conversations that we're having. The NIH, which, we all write to the NIH to get grants for research that we want to open at different centers. There's criteria. You need to have a certain percentage of minority patients in your study if you want to get this grant money. As a cancer center, you need to enroll a certain number of minority patients in your clinical trials if you want to get NCI designation. So these are things that are being put into place to really put pressure on institutions to include everyone in our society and reduce health disparities.
Absolutely. So let's talk a little bit about this, because I'm seeing a lot of questions about post-treatment. So someone is diagnosed with breast cancer, early stage, they've completed their treatment. They have been used to being monitored for quite some time. And then it's like, oh, I'll see you in 3 months. What should that monitoring look like for, whether you've had a mastectomy, whether you had a lumpectomy? What type of monitoring should they be anticipating with their doctors? And how do they know, especially when some patients undergo, MRIs and some don't go have MRIs? So what should they be expecting, and what is considered standard of care?
Right. That's a difficult, it's not, there's no generalized standard of care. The patient's age, the patient's risk factors, the patient's genetic testing, the patient's stage. Those are all the things that really guide what the management is in the survivorship phase. For a patient who's had a mastectomy, we're basically just going to continue to do mammograms, ultrasound as needed on the contralateral side. You can't mammogram a breast that doesn't exist. So we don't do anything on that side besides a physical exam to check the chest wall, to check the underarm. As it pertains to blood work for patients who've gotten chemotherapy, I definitely would do blood work every few months, at least every 6 months, just looking for any abnormalities, any signs of liver abnormality, elevated calcium, basically just looking for signs of, recurrence. Unlike some other cancers, CT scans such as chest, abdomen, pelvis is not standard of care in someone who's got early stage breast cancer. There are patients who maybe have some equivocal findings on your CAT scan prior to starting treatment, then a doctor may want to follow that. But if your pre-treatment scans, if scans were done to rule out metastatic disease, were unremarkable, it's not standard to continue to do scans in the survivorship phase. As to whether a patient gets an MRI, once again, that has to do with your age, the breast density, your genetic testing. Patients do ask about tumor markers. Tumor markers are not as reliable in breast cancer compared to, say, prostate and colon. Tumor markers are more helpful in the metastatic setting, not necessarily in someone who's got early stage breast cancer. So there are no guidelines to do that, even though some doctors do that. That may change. We have more and more sophisticated technology looking for circulating tumor DNA. So in terms of what standard of care is now, it could change in 2 months because we're constantly learning. So as of right now, we're not doing scans in patients with early stage breast cancers. We're just doing the standard mammogram or ultrasound to follow up and per routine recommendations.
Thank you. I want to talk about comorbidities, especially in Black women, Black people, not just Black women, because we know that men can get breast cancer too. But what is that, how do we navigate when we have other health conditions? You mentioned diabetes earlier, or we may have sickle cell or lupus. How do we go about navigating our care with all of this that we have going on with our health?
Yeah, generally during the active treatment for breast cancer, those things kind of fall behind. And then once the treatment is complete, that's once again going into the survivorship phase. All those things need to sort of, you need to start whether it's you're due for your colonoscopy, whether it's to follow up with your rheumatologist because you have lupus. We focus on trying to get patients who are overweight or obese into programs to help with weight loss, get nutritionists to help teach our patients how to eat. And then I think it's important when we even talk about weight loss and nutrition, we have the kind of foods that we like. Not everyone wants to eat carrots every day. So also finding a culturally sensitive nutritionist. I live in Brooklyn. A lot of our patients are from the Caribbean. They have foods that they like. We know food is cultural. It makes us feel great. So finding healthy ways to cook the things that are important to you within your culture, I think that's also important if we want patients to be successful. For patients who are smokers, we strongly advocate, smoking cessation, because that could increase the risk of breast cancer. For patients who are heavy drinkers, we also talk about reducing your amount of alcohol intake. So those are the things that we talk about in the survivorship phase that are important. And you got to keep seeing your primary care doctor. You got to manage your diabetes, your high blood pressure, all those things that were being done prior to breast cancer. What happens with a lot of doctors, because cancer is scary, not just for the patient, but for non-oncologists, they just kind of wash their hands off and just hand you over to the oncologist. So we also need to do better in bringing these doctors back. I will continue to see this patient for many years, every 6 months for many years, then maybe once a year when we're at year 8, 9, or 10. But I also need you to help manage their blood pressure and all the other things that I, as an oncologist, I'm not equipped to manage. So it's a whole village.
Thank you. And one question before we start to wrap it up. When it comes to genetic testing, this is a question that just popped back up. When we're talking about recurrences and we're seeing more and more women have recurrences. And sadly, we know that Black women are 39% more likely to have a recurrence of breast cancer. When we are diagnosed with these recurrences, should we get genetic testing again? Has things evolved or changed over time that we need to continuously get genetic testing? Even if we don't have a recurrence, should we get genetic testing within 5 or 10 years or 8 years? What are your thoughts about that, Dr. Taiwo?
Right. So genetic testing is your innate gene. So that doesn't change, right? As we become more sophisticated with the testing, we may find things that were not identified 20 years ago that we now know as pathologic. So it's not about getting genetic testing every time there's a recurrence as it pertains to genetic testing. It has the technology changed. So if I have a patient who was diagnosed 20 years ago and had genetic testing then, I will definitely retest them now. But a patient who got diagnosed with breast cancer 3-4 years ago does not require new genetic testing. Now, there is testing of the tumor, which is very different from actually testing the patient. We do test the tumor, sometimes at the time of diagnosis, sometimes at the time of recurrence, because we're looking for new mutations in the tumor that we may be able to target. So that is not called genetic testing. It's next generation sequencing. That's somatic mutations, looking for mutations in the tumor, which is very different from genetic testing, which is we're trying to find if there's an abnormality that predisposed or caused the cancer. And I know for all this talk about genetic testing, at the end of the day, it's talking to your provider. A patient who's 75 with DCIS or stage 1 hormone receptor positive breast cancer probably doesn't need genetic testing, but we may get to a place where we are testing everyone because we need more Black genes in the pool. The more genes we have in the pool, the more we're able to identify pathologic findings. We have all these VUSs, which is variants of unknown significance. 15, 20 years from now, those variants may actually mean something because we now have enough people who've been tested. So I know at my center, we have NCCN guidelines for who should be tested. Then there are other guidelines, the American, the NCCN guidelines are a little bit more conservative. You know, they use age, they use tumor types, but we try to test everyone. So if you're wanting testing and your provider is hesitant because you don't fall within the category, it may be a bit of a struggle and you may have to pay out of pocket. And that may be why it's not being recommended. But the conversation absolutely needs to be had because most Black women with breast cancer likely qualify for genetic testing.
Well, we have covered a lot of ground tonight. And I just want to say thank you so much for sharing all of the great nuggets with us and to Ativa and Novella for sharing your lived experience. And my last question to all of you is if you could give advice on what has or what is important to ensuring standard of care and understanding your treatment, what would that be? And Ativa, I'll start with you.
Your voice matters. So you may think all the treatment options are your most important tool. They do add to the special sauce. However, nothing really happens without your voice. So you have to scream if you need to, speak up, ask questions, always ask, and take somebody with you. And also remember the insurance company works for you too.
Novella?
I agree 100%. Speak up, ask as many questions as you need to ask, even if you're crying through it because the diagnosis is scary. Let your voice be heard and take away, like we said before, the angry Black woman syndrome. This is your life. If you don't speak up, then you could possibly be the one that will save your own life. You have to be an advocate for yourself. And like Ativa said, also bring someone with you. If you need someone to hold hands with you, your best friend, your sibling, your mom, bring someone with you that will give you that extra strength. Write it down. I wrote down a lot of questions so that I wouldn't panic and forget those questions. I had the notebook and I gave it to my doctor. These are the questions that I have, and start that conversation.
Thank you. And, you know, I would add to this, when you say your voice matters, your voice not only matters for you, but it also matters for the countless number of women that are going to be diagnosed behind you. Mm-hmm. So we're not only saving our lives, we're saving others as well. And Dr. Taiwo, I would like to ask that question to you in closing. What would you like to leave everyone who's tuned in to tonight's program?
Yeah, I think we're all kind of saying the same thing. We advocate for yourself. I think most doctors who are in oncology and just doctors in general, obviously doctors are human. They have good days and bad days, but most doctors are in there to do the right thing. And I advocate for yourself. Ask for second opinions. When my patients ask for second opinions, I support it 100%. It's not because they don't trust me, but they need to be comforted and they need to have that confidence that what you're telling them is what the next doctor is going to tell them. And if a patient doesn't trust me, I can't treat them well. So advocate, get a second opinion if you want to, and remain vulnerable, because that really allows your doctor to just sort of be there for you. It's hard, but bring the walls down. That helps.